So we'll start this session with welcoming Dr. William Bobiansolini from the University of Montreal, Canada. Thank you so much.
Good morning, everyone. Thank you for the introduction. Thank you, Dr. Mehta, for the invitation to present today. So today I'm going to talk about a new concept, which is the concept of fluid tolerance, a little bit different from the concept of fluid responsiveness. These are my disclosures. The main one is that I'm a co-chair of a pilot trial on fluid management on renal replacement therapy in the intensive care unit. I'm also the co-creator of the venous access ultrasound score. So this is the usual fluid balance trajectory in the acutely ill patients. You remember that there is a resuscitation phase, an optimization phase, stabilization phase, an evacuation phase. And there are those hinge points where you must decide when to stop further fluid accumulation because you decide that it is probably detrimental for your patient. There's also the hinge point that you decide to begin fluid evacuation. And finally, when to decide to stop or to reduce fluid removal because you're at risk of iatrogenic complication from fluid removal. Now, there are multiple surrogate markers of congestion and fluid removal. For example, fluid accumulation as a percentage of body weight, central venous pressure, peripheral edema, extracellular water measured by bioimpedance, natriuretic peptides, and various echocardiographic and peripheral venous Doppler assessment. These are all associated in observational studies with adverse outcomes. Okay? But there's a case to be made that all of these surrogate outcomes are, by definition, highly probable that there is residual confounding despite or adjustment efforts, because all of these surrogate markers are associated with the severity of illness and also the patient comorbidities such as heart failure. But nonetheless, based on these surrogate markers and those observational studies, the current hypothesis is that by reducing exposure to fluid accumulation, either by limiting the severity of fluid overload or limiting the duration of fluid overload, would entail a better patient prognosis. Now, considering the trend in fluid management in the intensive care unit, there was the area where we wanted to maximize cardiac output in studies of early goal-directed therapy in sepsis, where we were aiming for a CVP threshold. And on the outer side is the risk of fluid accumulation. And our current way to avoid these and maintaining this balance is to give fluid only when there is a state of fluid responsiveness, because there's a chance then we can increase the cardiac output. Now, this state of fluid responsiveness is not present very often after the initial resuscitation, so this approach, theoretically, is associated with lesser cumulative fluid balance. The problem here is that fluid responsiveness is actually a physiological state. Everybody here has fluid responsiveness right now. And past the initial resuscitation period, especially in some contexts such as sepsis, when you give fluid, the effect can be very short-lived. So after a fluid bolus, after 90 minutes, the hemodynamic effect is almost all gone. So considering this, the balance shift, we must choose between a temporary increase in cardiac output and maybe an improvement in tissue perfusion, and balance that with the probability of inducing fluid overload. So this is the concept of fluid tolerance, which is the degree to which a patient can tolerate administration of fluid without causing organ dysfunction. And typically, we can consider that this occurs when the patient becomes unresponsive to fluid administration. But in reality, in some patients, this fluid intolerance could be earlier in the course of the illness than when fluid unresponsiveness occurs. And this is a study in abdominal surgery when you see that overhydration through bioimpedance increased after surgery, but also fluid responsiveness increased. So those markers can vary in different fashion. So what does fluid intolerance look like? Well, I have two patient prototypes to suggest. One is one that Dr. Andrew Shaw talked about a lot yesterday, the venous hypertensive crisis, where you have a very high central venous pressure from cardiac dysfunction and reduced perfusion pressure, the differential between the arterial and the venous pressure. And there's progressive and often rapid multi-organ failure, resulting in severe AKI, ischemic hepatitis, sometimes also mesenteric ischemia. And you can see often those venous Doppler signs that are abnormal in the periphery and the portal vein, intrarenal veins. The other patient phenotypes that I would propose is the patients with an important inflammatory condition. And in this case, maybe the CVP is not that high, but you have, for example, pleural and ascites, so effusions. There is, for example, sometimes low CVP with a collapsed IVC, and oftentimes acute lung injury, and we must differentiate pure cardiogenic edema and ARDS, but it is kind of a continuum. And this condition could be self-perpetuating because when there is interstitial edema, the lymphatic system can be affected, and this interstitial edema can be difficult to resolve. And this has been explored as a thought experiment in a recent review paper in the context of AKI. You can see those two phenotypes. For example, the patient with pancreatitis that has been resuscitated but is developing acute lung injury with B lines, but maybe still fluid responsive, but maybe fluid intolerant. And the patient with more a cardiogenic pattern with maybe fluid responsiveness, but probably not, and fluid intolerance. But then let's now exit the realm of anecdotal and clinical judgment, and let's go see the evidence. So how do we define objectively fluid tolerance and fluid intolerance? And I would argue that the only way to do this is to test it in randomized control trial, and that's kind of what we do when we test a restrictive versus a liberal fluid balance strategy. Because then if we obtain a difference between cumulative fluid balance, and if there is no difference in outcome, then we can infer that within this population, people are mostly fluid tolerant. But if there is a difference in clinical outcomes, then we can infer that within this population, people are mostly fluid intolerant. So let's go see several examples of these types of trials. The first one is a really recent one, the Clovers trial, where patients at the first stage of sepsis, mostly in the emergency department, were randomized to an early vasopressor strategy compared to a liberal fluid strategy. And we obtained a separation of about -2 liters after 24 hours. The trials was stopped for no difference. As you can see, the 90-day mortality was similar, and there was no difference in severe AKI. And another study showed that in patients with initial AKI, there was also no difference in the rate of initiation of renal replacement therapy. Second trial, also in the first stage of sepsis, the FEAST trial, which was very different because done in a low-resource setting in children with febrile illness and signs of hypoperfusion, mostly malaria patients. And in this trial, there was a control arm compared with arms where children received fluid boluses, either saline or albumin. And there was, again, a significant difference in fluid balance after 48 hours. And in this trial, there was an increased risk of mortality in patients receiving fluid boluses. And after that, there was a recent reevaluation of this trial, and most patients after fluid bolus had a deterioration of the respiratory status and neurological status. So what's the difference between those two trials? There are many differences, but what I found interesting is that fluid tolerance is not only a factor of the patient characteristics, but maybe also a factor of the healthcare setting. After that, the classic trial, which happened a little bit later during sepsis, this was a trial of ICU patients after initial resuscitation, where both arms received about 3 liters of resuscitation fluids. And after that, there was a significant difference in fluid balance, but there was no difference in mortality and no difference in severe AKI. And there was also no difference in quality of life in further publication last year. There was in abdominal surgery, there was the RELIEF trial, a big trial of 3,000 patients, comparing a restrictive and liberal strategy. Again, a big difference in cumulative fluid balance of a little bit less than 3 liters. No difference in disability-free survival, but a greater incidence of AKI in the restrictive strategy, and a higher rate of surgical site infection in this group too. And after cardiac surgery, there's only one trial that I'm aware of, the fluid after bypass trial, which randomized patients to a protocolized fluid strategy based on stroke volume evaluation compared to usual care. Minimal difference between arms of only 500 cc's, and no difference in ICU stay. A little bit higher hospital mortality in the protocolized arm, but this was not significant if multiplicity was taken into consideration. Let's go on to the FACT trial. In this trial, you know it probably well. Patients with ARDS were randomized to a conservative or liberal strategy. This is a negative trial because there was no difference in mortality, but there was a difference in ventilator-free days. And what is interesting in this trial is that we are able to phenotype ARDS and identify subphenotypes of ARDS. And this results went a little bit against my prior bias because phenotype 2, which had a higher inflammatory phenotype and more sepsis and a higher CVP, where the mortality in this group was actually lower in the liberal fluid management group, going a little bit against my prior bias. In pancreatitis, in the New England Journal of Medicine, again, moderate to between moderate and aggressive fluid strategy, a difference in fluid balance. It was altered prematurely due to severe events, more fluid overload, driven by mainly pulmonary congestion. There is pilot trials in AKI in RRT, looking at fluid removal, and one that is finished in patient not on RRT that shows that the restricted fluid management based on restricting IV fluids and diuretics treatment can lead to a modest reduction on cumulative fluid balance and maybe lesser rate of RRT initiation. But another trial that we can look at, it was not a trial namely on fluids, but the START-AKI trial. When we wait before initiating renal replacement therapy, the natural conclusion is that fluid can accumulate more. And there was a difference in fluid balance at RRT initiation, which was quite substantial in this trial, but there was no difference in mortality, and sub-analysis showed that the fluid balance at randomization was not associated with a difference in the impact of accelerated RRT initiation. So let's, at the end, return to fluid tolerance. So after thousands of patients randomized in these trials, fluid tolerance remained elusive. So I don't want to make the creeping of fluid nihilism right now. I think there are very important trials, and I think we must continue to work on this subject. And I think we must think about fluid tolerance, even if it's a theoretical concept, to guide the design of these trials. And what are future avenues? Can we strive to achieve a greater difference in fluid balance? Maybe, since we demonstrated that in some conditions, the strategy is safe. There is no increased mortality with a restrictive strategy. Maybe we can strive to achieve a greater difference. But I think the way forward is capturing detailed information about those patients and trying to phenotype them, because some subgroups may be more likely to be fluid intolerant within those big ICU syndromes. And subgroup of interest, for example, septic cardiomyopathy, intra-abdominal hypertension, and also seeing if the hemodynamic effect can be transient or sustained in patient receiving fluids. Thank you very much for your attention.
Thank you very much, William, for your great contribution.